So what are some of the affective variables that people have been exploring? And just looking around your hallways, I've noticed that there is some interest here in terms of affective variables. So some of these affective variables in context of technology that are being explored are issues of hope, happiness, curiosity, optimism, etc. Sense of flow, sense of control, confusion, boredom, frustration, resilience, disgust, stress, and sadness. Now, all of these are very interesting variables, and we have to sort of think of how you're actually going to assess them in the context of learning, especially in the context of learning with technology. And multi-channels of communication, of affect and communication, are needed to actually have a good read on what emotions are occurring and how to classify them. And there are, Art Gracer is doing a lot of work in that area. And some people are using what they call physiological sensor assessments, even in classroom research, where they'll hook up students as they're learning using technology in classrooms to see how engaged, bored, sad, happy, in sense of flow in the context of learning mathematics and things like that. And Beverly Wolf is probably doing the most cutting-edge work in that area. Then there are people that are actually looking at empathy using technology, teaching adults with Asperger's syndrome to recognize what an emotion is, because this is a complex where individuals have a hard time understanding social boundaries or affective emotions, and so they're using interactive multimedia to teach Asperger's adults about these things. So how do we detect affect? There's many ways. There's motor expressions, Ekman's scale of facial coding, looking at your face, your voice, your gesture, for how happy, sad, bored, etc. There's subjective self-import data, which many of us have used for a long time. There's action tendencies with these posture seats that people have been using to see how squiggly people are in their seats. The more they move around, the more bored they are. Or are they leaning in is also a form of engagement versus leaning back, which is a boredom indicator. So again, the physiological sensors that are hooked up to individuals, and appraisal, cognitive arousal sorts of situations. So there are all sorts of affective detection devices, and you sort of have to pick which channels you're going to be focused on when you're doing some affect research in the context of learning, since, as you can see, they're very complex and varied. So what does affect, caring, and technology, how do they all come together? And one way that I looked at this was looking at Nell Nodding's research on caring, and she is probably most known for work in caring for teachers and teacher educators, and how teachers, like in teacher training situations, how do you teach teachers to care? And so there are 3 dimensions of caring: reactive, responsive, and receptive. And so when you talk about reacting to individuals, can computers react to individuals? Well, we know that they can adapt to learners in terms of the intelligent tutoring scenarios that have been developed. They can adapt by giving adaptive forms of feedback, so they are reactive. Are they responsive? Well, caring means that there's a reciprocal relationship. And so if you look at caring in learners, between a learner and a computer, learners could actually care for these personal agents by keeping them informed and training their agents what they know. And so you can have a responsive relationship between a learner and a computer. In terms of agent findings, there's a lot of work on that. Are computers receptive? Intelligent tutoring systems and pedagogical agents often take on roles of mentors, tutors, and give different forms of feedback based on the situation, where students are communicated to by tutors or agents in the context of either words, text, speech, or gesture. And so tutors and agents can be receptive to learners. And so I guess what I'm saying is, can computers care? If your definition is reactive, responsive, and receptive, then I would say that they meet those conditions. If you look more carefully at Nell Nodding's work on caring, she talks about these 4 dimensions of modeling dialogue. practice and confirmation. And so again, she was talking about how humans model caring for others, and how you don't merely tell someone to care, you demonstrate how to care. And most of us who do work in artificial intelligence and education from the intelligent tutoring perspective are very interested in modeling human behavior using technology, whether it's expert performance through guidance or whatever. The student models of performance are updated in a dynamic way so that you're giving feedback. So my question is, if we can model cognitive competencies, why can't we model caring competencies? And that's one of the things that the future research I'm hoping we'll look at. In terms of dialogue, as we try to care, we're helped in our efforts by the feedback we get from the recipients of care. So in a teaching situation, that would be the students. Do the teachers get feedback from their students that they actually care for them? In a medical situation, it may be doctor-patient. Are the patients feeling cared for? So in terms of the technology, tutorial dialogue can have the same feedback effects that a human coach could have, and they could provide, again, both cognitive and motivational feedback in terms of dialogue. Practice. We need to give students practice in caring and reflection on their practice. So again, Erickson's model of deliberate mindful practice of learning can also be applied, I think, to caring. Why can't we provide a deliberate practice environment that helps people care? Confirmation is basically helping a cared one actualize their true self. So can you help people affirm through feedback that they can learn to learn through metacognitive feedback, or can they learn to self-actualize or regulate their own emotional affect in the context of learning? Okay, so that's sort of the basis of the modeling, the caring, and as Susan said, I've been thinking about computers as cognitive tools for many, many years. And there have been, I guess it's now 3 decades that we've been looking at modeling from different perspectives, and there have been various debates that have led us to think about how we can model performance. You know, normally we think of modeling performance, modeling, a human modeling for somebody else, an individual model of performance. So you have the individual models. And those of us in artificial intelligence have been interested in how computers could model human performance and how we can provide dynamic feedback in the context of technology. But then there was a revolt saying there's no way that computers can possibly model everything an individual knows. And so there was sort of like, let's throw away modeling altogether by computers and think about modeling back to how the group in a social constructivist model would support learning, or how an individual human might model learning. And then the second decade was sort of throwing away the whole idea of whether we should model or not model, but that yes, modeling is important, that it can be done by individuals, computers, and groups. And I guess now we're at the question of what is it we're modeling in this decade. So for years we've been talking about cognitive models through expertise, how we model cognitive competencies of expertise. Now what I'm arguing for is that we have to link the brain and heart and have both cognitive competencies and affective competencies. And that we should be thinking about how teams and groups learn together, and we should also be looking at cultural differences and how that might affect learning. So we're sort of broadening the concept of what to model and how to model it using technology. So can computers teach health professionals to think and care? So going back to Nell Nodding's model, she says that modeling, dialogue, and feedback that supports learning in medicine should be done, and that we should provide practice opportunities and confirmation activities that you're on the right track. And so what I'm saying is that caring without expertise and expertise without caring may be problematic. And if you look at the whole medical expert, there are affective parts to being a medical expert that need to be thought about, such as communication with patients, professionalism, collaboration, health advocacy, etc. So how can we use computers to teach health professionals to think and care? So if you look at this human doctor in this cartoon, we're seeing whether this doctor is reactive, responsive, and receptive to his patient. And he's saying, of course I'm listening to your expression of spiritual suffering. Don't you see me making eye contact, striking an open posture, and leaning towards you and listening to your suffering and nodding emphatically? Well, in this sense, you can see that the physician is using an emotional checklist of how to care for his patient. And so this is, just as static as you would think that technology sometimes could be very cold. Well, I think humans can be cold too if they're learning to just sort of follow a checklist without actually knowing how to care. So all this to say that I'm thinking of cognitive tools in this decade and what we need to change in terms of our theories that drive the models of technology that we use. So I'm still very interested in models of expertise, of how people learn, and I'm interested in situating learning in an authentic context so that people learn in meaningful activities. And I'm also interested in social constructivism in terms of how the group supports a learning situation. And I think these three theories fit very well into a cognitive apprenticeship model that includes the domain knowledge of the subject matter that you're trying to teach, as well as the teaching aspect in terms of how you scaffold, model, and aid assistance as learners are learning, and how you use the social aspects of learning to promote argumentation and collaboration. These are all very important things to include in your new technologies for learning. But what's been missing up until now in the model has been how do we model things like passion, persistence, confidence, curiosity, engagement, identity, resilience, and all these wonderful affective variables. How do we now get those all together and have the cognitive competencies and the affective competencies? So, just to repeat myself, we need to look at identifying different levels of proficiency in our expertise models, and we need to help the less proficient become more proficient by scaffolding them through feedback that will help them become more expert, help them regulate their learning by giving them corrective cognitive components to learn in an effective learning situation, situate learning in authentic context with scaffolding. And now, how do we go back to William James and connecting the mind, body, spirit as connecting affect and emotions in the context of the mind? So I'll give you some examples from our own work in cognitive apprenticeships in medicine. I'll give two examples of one called BioWorld and one is called the Deteriorating Patient, both of which Dr. Wiseman has worked on. And I'll talk about how we've been exploring the role of affect and caring in these medical contexts.